Hello. I didn't have a chance to do my lecture stream yesterday, so I'm going to do it today, the day of the exam. So, but I'm going to do it while I get ready. So it'll be a kind of like a get ready with me while I explain things that nobody cares about except for me. So that's great. My mirror is actually very fogged up right now, and I don't know how to fix that except wait for this fan to finish off its job. So we'll do that and see how it goes. Okay, so hold up. Okay, so first we're going to talk about respiratory system, obviously. Some of the components of the respiratory system responsible for gas exchange, blood pH regulation, voice production, and olfaction. And there's some types of respiration. There's pulmonary respiration, which is breathing, external respiration, which is the gas exchange between the pulmonary capillaries and the alveoli, and internal gas exchange, which is the systematic capillaries and cells. And then there's also gas transport within the lungs and the tissues, with the lungs and the tissues. So there's two types, or there's two parts to the anatomy. There's the conducting system, and then the respiratory system. The conducting system is the nose, the nasal and oral cavity, and then the pharynx, larynx, trachea, left and right primary bronchi, the secondary bronchi, and then the segmental or tertiary bronchi, and it ends at the terminal bronchiole. And there's also a diaphragm is part of that. So there's two types of bronchioles. It could either end at a terminal bronchiole or move on to the respiratory bronchiole. The respiratory bronchiole is where the respiratory zone starts. So it goes from the respiratory bronchiole, branches out more to the alveolar duct, the alveoli, and the pulmonary capillaries. So there's detailed anatomy on all of this because I only went through like the main ideas. So the pharynx has three parts. There's the nasopharynx, the oropharynx, and the laryngopharynx. The oropharynx allows only air, and there's also the uvula or something like that. That's the thing in the back of your throat that like looks like a teardrop. And you have the oropharynx, which allows air and food, as well as the laryngopharynx, which allows air and food as well. The larynx has the epiglottis and vocal folds. After that, you move on to the trachea, which is a hyaline cartilage C-shaped ring tube that has goblet cells that secrete saliva, and then cilia, which help like move and like uh, direct the flow of that mucus. When you smoke, those cilia are the ones that become paralyzed when you smoke. Uh, then you move down to the lungs where the alveoli are. And so an alveolus is a site of gas exchange basically. There's surfactant, which reduces the water tension of the alveoli and prevents the collapse of the alveoli. There's also type 1 and type 2 alveolar cells. Type 1 alveolar cells are thin and help exchange that oxygen and carbon dioxide. And type 2 alveolar cells help secrete the surfactant we were just talking about. So these two types of cells, along with macrophages, I believe, they make up the alveolar and pulmonary capillary epithelia. So these two, the alveoli and pulmonary capillaries, have a fused membrane. The lungs are attached to the thoracic wall via pleural suction. There's the visceral pleura, which is attached to the lung, and then there's also parietal pleura, which is like the outside of that pleura. Basically, atmospheric pressure is 760, and it's also known as PATN. And the pressure in your lungs, which is the intrapulmonary pressure, which is PALV, It is in general the same as atmospheric pressure, which is 760 after inspiration and expiration. So PALV will always equalize with the pressure. Now, intrapleural pressure, which is on the outside of the lungs, this will be PIP, and this will almost always be -4 below the atmospheric and um, lung pressures. So you have two types of respiratory mechanisms. You have inspiration and expiration. So inspiration is you taking air in, and the intercostals and the diaphragm contract, which expands the chest wall and the parietal pleura. So that's your you breathing in. So the diaphragm will be moving out or down, and the intercostals will be moving out as well. The intrapulmonary volume and the intrapleural volume will both increase. However, the intrapulmonary pressure and intrapleural pressure will actually decrease by just a little bit. So naturally, the intrapulmonary pressure is going to be 760. Now, during inspiration, it's going to drop to -1 below PATM, right? And then after inspiration, it's going to go back to normal. For intrapleural pressure, it's going to go from -4 below PATM to -6 below ATM. And at the end of inspiration, it's still at -6. Um, Now, during expiration, that's when your intercostals and diaphragm relax. So your chest moves in, your diaphragm moves up, and then the parietal pleura are kind of like pressed on to become inwards. So this is when your intrapulmonary and intrapleural pressure or volume both decrease, right? And then at this point, your intrapulmonary pressure will raise to like +1 above 8 PATM, and then it'll return back to normal after expiration is finished. Now, intrapleural pressure, it increases back to -4 below PATM at this time, and it doesn't change after expiration. So it gradually just basically increases back to -4 below a PATM. Okay, now we're going to talk about capacities. The total lung capacity is the total amount of air that your lungs can hold. So this is like all the air that you could possibly hold in your body at one certain amount of time, at a given point. Your tidal volume is the amount of air that, like on average, moves in and out while you breathe. So during inhalation, exhalation, whatever. And then your inspiratory reserve volume is the amount of air that you can inhale beyond regular. So that's like the amount of air that you can force inhale. The expiratory reserve volume is the amount of air that you can false exhale. Your vital capacity is all the air that can be exhaled after max inhalation. So this is all the air that you will be using for your gas exchange. The tidal volume, the vital capacity is all the air that you can like hear basically moving in and out of your body. So like if you're breathing, that's all the air that you're using. That's tidal volume. That's not all the air in your body, but that's all the air that you're using for gas exchange. Now, what's all the air that you're not using for gas exchange then? This is your residual volume, which means that whenever you breathe out as much as you can, there's still some air left in your body. That's the residual volume, which will be stuck in your conducting zone, which is your respiratory system. And it won't be used for gas exchange because it's stuck in there. Your inspiratory capacity is the amount of air that can be inhaled after normal exhalation. So, like if you exhale normally, that's all the air that you can breathe in. So that's your tidal volume plus your inspiratory reserve volume. And your functional residual capacity is the amount of air remaining in lungs after normal exhalation. So this will be your residual volume. Sorry, what? Yeah, this part. After normal exhalation. So this will be your residual volume on the bottom, plus your expiratory reserve volume, because it'll just basically be all the air that is remaining in your lungs after you breathe in and breathe out. The amount of airflow per minute, this is important. This is a equation for a math problem. This is your tidal volume multiplied by your respiratory rate. Now, this is just the amount of airflow per minute. If you want to calculate your alveolar airflow or your fresh airflow per minute, now you want to do respiration rate times tidal volume, but you also need to account for that dead space or like the residual volume or like the conducting zone, right? So you want to do tidal volume minus dead space and then multiply that by the respiratory rate. There's two types of dead space. Anatomical dead space is basically like the space that holds like the amount of air in your conducting zone. And then functional dead space is basically like if you were to put on like a gas mask or something like that, some air is going to get stuck in that gas mask and you can't use it for gas exchange. So if you were to be given a problem with and then told to calculate the alveolar ventilation rate, you just need to account for that, what information is given to you. So like if you have that like conducting zone capacity, then that's your that's your anatomical dead space. If you have a breathing tube or something like that, and it shows that capacity of that breathing tube, then you want to add the anatomical and the functional dead space together, and then that will give you your like total dead space that you can account for in your equation for alveolar ventilation rate. So partial pressure is a proportion of the total pressure that a certain gas contributes to the atmospheric pressure. So it'll be a percentage of PATM. Usually you're accounting for oxygen, carbon dioxide, and water. Sometimes it's also nitrogen. And in general, water is 21%, or oxygen is 21% of PATM. And then carbon dioxide is 78%. And then water is negative 1%. If the problem is asking for calculating based on dry air, then you don't need to calculate based off of that water droplet. You just need to calculate off of like the two amounts of gases given, and those two percentages should add up to 100, and you don't need to account for that 1% water. Now, if it says it's hydrated air, then you probably should account for that 1% water. Usually when air is moisturized by the body, which means there's vapor pressure, the P of H2O is usually 47. So when you do your calculations of oxygen and carbon dioxide, you would do the percentages based off of PATM minus PH2O. So like 21% and 78% of PATM minus PH2O. A gas will always move from higher to lower partial pressure of that gas. Factors affecting PO2 and PCO2, there's the partial pressures of the inhaled gas will affect that, and the alveolar ventilation rate also affects the pressure in the alveoli. The rates of oxygen consumption and CO2 production will also affect those rates. So something to keep in mind in the body, when you inspire air, the PO2 of your inspired air is usually 100, right? And then your CO2 is usually 40. So when it reaches your lungs, it's going to be 100 for oxygen and then 40 for carbon dioxide. When it moves to your oxygenated blood to go to your body, it keeps that same configuration, so 100 over 40. When it goes to your tissues, however, it's going to become deoxygenated, so it's going to be, PO2 is going to be less than 40, and then PCO2 is going to be a little bit more than 45. So when it goes to your deoxygenated blood, PO2 is 40, and then PCO2 is 46, and it'll go back to the alveoli. So in general, when it goes to your capillary and your cell, the PO2 and PCO2 go from 100 to 40 to less than 40 and more than 45. Okay, so now we're going to talk about the different types of gas transport. You have obviously oxygen and carbon dioxide. However, there's two types of like the transport. So there's transport at the tissue, so like from your blood capillary to your tissue, and then there's also from your blood capillary to your alveoli. for like gas exchange on both ends. First, we're going to talk about the tissue. So for oxygen, there's two types of ways this can be diffused in your system. So first of all, um, it can either be dissolved in the plasma, or it could like oxygen could either okay sorry at the tissue. Basically what the goal is you're trying to get oxygen into the tissue and carbon dioxide out of the tissue, and then blood is receiving carbon dioxide and giving oxygen, right? So blood can either be or oxygen can either be dissolved in the plasma and go straight to the cell, or it could already be in the red blood cell, bind it to hemoglobin, and at that point it'll dissociate from hemoglobin and go right to the cell. So these two ways um, are the main ways that oxygen will go to the tissue, and one is more popular than the other. So like it's oxygen is not really like soluble in water. So when I say that like it can dissolve in plasma and go right to the cell, that's only 2% of oxygen. Now the rest of the oxygen, which is 98%, it will be in the blood, binded to hemoglobin, and then it'll dissociate and move to the cell. Now carbon dioxide, however, that's in the cell already. Now it's trying to go out. This is a different story. So 10% of that will go directly to the plasma and like uh, diffuse with the plasma. And 10% is higher than 2% oxygen because carbon dioxide is a lot more soluble in water than oxygen. So it makes it a lot easier for carbon dioxide to be in the plasma. So that's 10% of the carbon dioxide will be in the plasma by diffusion. And then 20% will become a carbamino hemoglobin. What this means is it goes into the red blood cell and binds with hemoglobin. It's pretty rare as well. Now, 70% of that carbon dioxide, because we already talked about 10 and 20%, which is 30%, what happens to the other, 70%? So that 70% can it can do two things. So both of these, the 70% will become a bicarbonate ion, and how it becomes a bicarbonate ion, there's two ways of going about that. So the first way is a slow reaction. It can either move to the plasma, right, and have a reaction with water to become bicarbonate and a hydrogen proton, and that is a slow reaction because that's again in the plasma. Now, if it wants to go to the red blood cell, it will have to have that reaction with water in that red blood cell, and if it does that, it's going to be aided by no, carbonic anhydrase, right? So when it's aided by carbonic anhydrase, that's a fast reaction, and then it'll become a bicarbonate ion, and it's to pumped out of that red blood cell into the blood in exchange for chlorine, and then the hydrogen proton from that it'll merge with hemoglobin to become reduced hemoglobin. Now at the alveoli site, it's basically the same thing, but now you're trying to move the oxygen from the red blood cell to the alveoli, and from the alveoli to the red blood cell, and then carbon dioxide from the red blood cell to the alveoli. So again, 10% will be dissolved. 2% of oxygen will be dissolved in plasma. 98% will bind to the hemoglobin in the red blood cell. And then for carbon dioxide, 10% has been dissolved in plasma, so it will go straight to that alveoli. 20% has been transported by hemoglobin, and so it will dissociate and then go right to the alveoli. And then 70% can either do a slow reaction with a hydrogen proton to become carbon dioxide and water and then go to the alveoli, or a fast reaction aided by carbonic anhydrase by pumping in bicarbonate into the red blood cell, and then in exchange for chlorine, and then reacting with that hydrogen proton to become carbon dioxide and water, so it can be put into that red blood cell. Now we're going to talk about the oxygen and hemoglobin dissociation curve. So this helps explain the relationship between oxygen saturation and the pressure of oxygen in the blood. So your lungs, the pressure is usually 100, and then for your resting tissue, it's usually 40, and then for exercising tissue, it's usually 20, which for the pressure of oxygen. And a 100% saturation means that all four, because there's four total possible, all four oxygen atoms have or molecules have bonded to hemoglobin. So like basically, when this happens, it means there's low affinity for oxygen because the uh, the red blood cell is already full, like the hemoglobin is already full. So there's like a lower affinity. A higher affinity would mean that there's less being bonded, like less red blood cell being bonded to hemoglobin, which means that it's more hungry technically. So there's more affinity. So at the lungs, all four O2 has bonded to hemoglobin. At the tissue, only three um, is bonded to hemoglobin, and one is in the tissue. And then in exercising tissue, there's three. Um, sorry, at the resting tissue, there's one oxygen in tissue, and then three on hemoglobin. And then at the exercising tissue, there's three oxygens in the tissue, and then one in hemoglobin. Now, a right shift, which you can see in anemia patients, will indicate more oxygen being delivered to tissue, so there's more release for oxygen being in the tissues, and then there's higher carbon dioxide, higher acidity, which means a lower pH, higher 2,3-dipropylglycerate, which is DPG, and this promotes oxygen release, higher exercise, higher temperature, and a lower affinity. So again, more oxygen delivered to tissues means higher carbon dioxide and lower affinity. And there's also more red blood cells in general, or sorry, less red blood cells. Now, less shift, which you can see in a fetus, this means that there's a higher affinity for oxygen, so there's less being delivered because the fetus is trying to keep that oxygen. And yeah, what this means for anemia patients is that there's since there's a lower affinity for oxygen in their bodies in a right shift, there's less oxygen being kept in their body, so they get tired more easily. Okay, so respiratory physiology or pathology, you have pneumothorax, which we discussed before about the partial pressures of the pleura and the alveoli. So pneumothorax is a thing where one of your lungs has been damaged or hurt, and this causes your pleural pressure to be the exact same as your alveoli or your atmospheric pressure. So the PIP becomes the same as PATM instead of -4, and then the lung can't compress properly, and it also is deflated basically, like it can't work properly. So the treatment for that is a chest tube or surgery. Then you have emphysema, which is the destruction of alveoli, so there's less surface area for gas exchange. This does not affect respiration, however. So in the alveoli, there's a normal amount of oxygen, but there's a low amount of carbon dioxide because it's receiving less from the pulmonary capillaries. In the pulmonary capillaries, however, there's a low amount of oxygen because it's not receiving as much from the alveoli, and then there's a high amount of carbon dioxide because it's not giving as much to the alveoli. For fibrotic lung disease, this means there's a thickened alveolar membrane and slower gas exchange, just kind of like emphysema, except now the alveolar membrane, it doesn't affect respiration, but it does affect how much air goes to the alveoli from that respiration. So in the alveoli, there's low PO2 and there's high CO2 because again there's like less communication between the alveoli with the outside breathing, but also the pulmonary capillaries. And in the pulmonary capillaries, there's low PO2, high PCO2, obviously. For pulmonary edema, um, this means the interstitial fluid will increase the amount of diffusion distance. So there's more distance that you have to travel to for gas transport. Now this doesn't affect the alveoli one bit, pretty much, because well again, pulmonary edema doesn't affect the outside breathing and the receiving of oxygen from like the lungs to the alveoli. So there's not really a problem there. So there's a normal amount of oxygen, and it's also a normal amount of carbon dioxide for pulmonary edema because carbon dioxide can diffuse easier into plasma than oxygen can, which means there's a like from the pulmonary capillaries to the alveoli, it's pretty easy diffusion there for carbon dioxide. So in the alveoli, there's a normal amount of oxygen, a normal amount of carbon dioxide. However, in the pulmonary capillaries, there's a low amount of oxygen. However, the amount of carbon dioxide is pretty much the same. For asthma, this is an increased airway resistance and a decreased airway ventilation. In the alveoli, this again affects the breathing, so there's low oxygen and high carbon dioxide due to that low oxygen. And then in the pulmonary capillaries, there's a low amount of oxygen and a high amount of carbon dioxide as well. Now we're going to move on to the digestive system. The functions for the digestive system is ingestion, propulsion, physical and chemical digestion, absorption, and elimination. So the mouth is responsible for ingestion and mastication, which is chewing, enzyme hydrolysis in the mixed bolus. The esophagus makes the bolus or propels the bolus via peristalsis. The stomach is responsible for churning, hydrolysis, storage, and mixed chyme, which is basically half digested food. And then the small intestine is responsible for segmentation, hydrolysis in the first place for absorption. The large intestine is a secondary place for absorption, but it's more like for water, ions, and vitamin K. The rectum is the storage of waste, and the anus is the expulsion of waste. There's 4 classes of food. There's proteins, which are amino acid chains connected by peptide bonds. Carbohydrates, which are sugars, which can be monosaccharide, which is glucose and galactose, or disaccharide, which is lactose. Nucleotides, which is a ribose phosphate group and nitrogenous base. Lipids, which are 3 fatty acids connected to glycerol. And some kind of like key notes for suffixes: ACE will be an enzyme, OS will be a sugar, OGen is a precursor or an inactive form that needs to be activated before it can work. So we're going to talk about some detailed digestive anatomy. The mouth is responsible for both mastication and hydrolysis, which means chewing and then a little bit of salivary digestion. This will create a bolus. The food is sensed by chemoreceptors on the fungiform. The extrinsic muscles will elevate, depress, protrude, and retract, and intrinsic muscles will shorten, widen, and lengthen. There's 2 enzymes and glands in the mouth, so there's lipase and amylase, which will help digest lipids, and amylase will be starches, carbohydrates. So amylase is made by the parotid gland and the submandibular and the sublingual glands, but mainly the submandibular. And then lipase is made by the von Ebner's gland, and both of these will be in your either your saliva or tongue. So amylase will be on your tongue, mainly, and then amylase, lipase will be in your saliva. The esophagus is not responsible for any type of digestion or absorption. However, it helps move and propel the bolus down the tract via peristalsis. There's 2 sphincters. There's the esophageal sphincter, which is a true sphincter. This is a voluntary muscle that relaxes to let the bolus through. The gastroesophageal sphincter is fake, and it's a hole in the diaphragm that lets the food through, but also prevents the stomach acid from entering the esophagus. The stomach helps the bolus entering from the gastroesophageal sphincter. and it's churned with gastric juice, hydrolyzed and hydrolyzed by pepsin, and pepsin breaks the protein uh, and turns to chyme and exits by the pyloric sphincter. Um, so basically, in the stomach, lipids and proteins are digested there. And then in the small intestine, pretty much everything is digested there. Give me just a second. Okay, yeah. So only proteins and lipids are digested in the stomach. So the surface epithelium of the stomach, it has like a whole bunch of cells. The main idea is basically it secretes viscous uh, alkaline bicarbonate mucus, which protects the stomach. So the mucus neck cells will make the mucus at the neck of gastric glands, and then the parietal cells will secrete hydrochloric acid that kills bacteria and activates pepsin, and the pepsin will denature proteins. So the HK-ATPase pump will help primary active transport and pumps hydrogen into the stomach. The bicarbonate chlorine antiporter helps pump the bicarbonate into the blood and chloride out, which we saw earlier with the gas transport. The alkaline tide means the blood in the veins is more basic than arterial blood because the parietal cells secrete acid, the hydrochloric acid, into the stomach lumen and bicarbonate across the membrane. The third type of cells are chief cells, and these help secrete pepsinogen in small amount of lipase. So again, these are for protein and lipid digestion in the stomach. Enteroendocrine cells help secrete hormones. So this includes gastrin, which stimulates hydrochloric acid production and stomach motility. There is histamine, which activates parietal cells, and again, the parietal cells help secrete the acid. The endorphins, which suppress the appetite, the serotonin, which helps with stomach contractions, and then somatostatin, which helps inhibit the stomach motility and secretions, and this is important for when you're full. The accessory organs include the liver, gallbladder, duodenum, and pancreas. The small intestine is folds of mucosa and submucosa with villi and microvilli, also known as brush border. So this small intestine can basically digest anything, um, and the duodenum is where most of that digestion occurs. It receives chyme, acid, bile, and enzymes. The second part of it is the jejunum is where most of the absorption occurs, and then the ileum is important for vitamin absorption. Now, in the small intestine, this is what all can be digested. Proteins can be digested by trypsin and chymotrypsin, as well as brush border peptidase. Carbohydrates can be digested by amylase and lactase. Nucleotides can be digested by brush border nucleosidase, and lipids are digested by bile salts and lipase. The pancreas does not digest, but it produces digestive enzymes for fats, carbs, and proteins. So the exocrine cells help secrete bicarbonate, which neutralizes gastric acid. It also secretes amylase, which digests starch, lipase, which digests lipids, and proteolytic properties, which digest proteins such as trypsin and chymotrypsin. Endocrine cells, however, they are organized into islets and secrete hormones into the bloodstream. Alpha cells will help secrete glucagon, would help break down of glycogen into glucose, and then insulin, which helps the build up of glucose into glycogen, and then delta cells, which help secrete somatostatin, which again inhibits the secretion of glucagon, insulin, and stomach secretion in general, and inhibits the motility and secretion. Um, Now, the large intestine is rich in microorganisms. It helps absorb water and inorganic ions like sodium, and this creates the osmotic gradient. Too little absorption will lead to diarrhea. Too much will lead to constipation. The path of uh, water and ions in the large intestine. So it'll go to the ileocecal valve, which is the junction of the small intestine and large intestine. So the ileum of the small intestine and the cecum of the large intestine. Then the appendix in the large intestine cecum. Then the descending colon. Then the sigmoid colon, the rectum, and the anus. I forgot to mention liver. This is the metabolism and storage of nutrients. So in the liver, you can store glucose as glucagon as well as lipoproteins as triglyceride. Um, and for it helps with metabolism, storage, detox, bioproduction. So the path of blood in the liver, it goes in by hepatic artery and the portal vein. So oxygen-rich blood goes in by the hepatic artery, and then nutrient-rich blood goes to the portal vein. Um, and after that, it goes to the sinusoid capillary, then the central vein, then the hepatic vein. The path of bile, it's made in the liver, and then it goes to the hepatic duct. So the hepatic artery, portal vein, and the hepatic duct are the hepatic triad. But anyways, the bile goes from the liver to the hepatic duct, then storage in the gallbladder. Then CCK will prompt the gallbladder contraction, releasing bile. This will then go to the cystic duct, the common bile duct, the duodenum, and then the ileum, where the bile fats or the bile salts and the fat are absorbed. Okay, last part. The digestion. So proteins are digested by brush border peptides, trypsin, chymotrypsin into amino acid. Carbs are digested into the brush border lipase, saliva, DNA. Saliva and gastric amylase into monosaccharides. Nucleotides are digested from Si nucleosidase into phosphate and sugar. Lipids are digested by bile and lipase into monoglyceride and fatty acids. And then absorption, there's three. So let's talk about the monoglyceride and fatty acids. So these are absorbed by the diffusing through the epithelium, forming a chylomicron, and then being exocytosis to the lacteal vein and then to the blood capillaries. There's no active transport. While the other three, for amino acids, simple sugars, and phosphate sugar base, these are all used by sodium co-transporters. And so this is the apical way. These are used by co-transporters to diffuse to the capillary, and then facilitated diffusion on the basolateral side to go to the capillary. So again, for the three, it uses active transport through a co-transporter, sodium co-transporter, and facilitated diffusion. And only the fatty acids use diffusion and then going to the lacteal. So there's a control of digestion. The cephalic phase is the first phase. It activates the parasympathetic nervous system and acetylcholine, which then causes salivation, as well as secretion of lipase, amylase, gastrin, hydrochloric acid, and stomach motility. The hormone mechanism includes the second two phases, the gastric phase, which means the food will cause gastrin, hydrochloric, pepsinogen secretion, and churning, and then the intestinal phase, which lowers the motility when you're finished. So chyme can either go two ways. Chyme can be digested into fat, and then CCK, and then lipase, which then lowers motility. Chyme can also go to HCl, then secretin, then bicarbonate release, and then also lower motility, HCl and pepsin. The last control of digestion is the neural mechanism. The enteric nervous system gastrocolic reflex means food will, the presence of food will make large intestine move the chyme. And then the autonomic nervous system, so the sympathetic lowers secretion and motility, and parasympathetic increases both. So some pathology, GERD or heartburn. This means, sorry, let me check this real quick. Okay. Gastric juice will go up the esophagus due to hiatal hernia, excessive eating, or pregnancy. And then ulcers are caused by Helicobacter Helicobacter pylori, which is 95% of gastric ulcers, and this results from chronic aspirin use or acid in the acid in the SI will cause a duodenal ulcer. This will also cause inflammation and stomach lining damage due to higher gastrin acid. Cholera is caused by Vibrio cholerae. This produces a toxin that binds to the small intestine and prevents water and electrolytes from absorbing, which means higher secretion and can lead to dehydration as well as diarrhea. Jaundice is a yellowing of skin and eyes caused by blockage of bile duct, and diabetes is too much glucose in the bloodstream. The treatment for this is dialysis. The presence of insulin will mean that it's type 2, meaning the insulin receptors are desensitized to insulin. No presence of insulin will mean that there's type 1, which means there's no insulin made. Okay, that's all. Bye.